Good morning. On behalf of the Patient Safety Authority, I'd like to welcome you to this web conference titled The Value of Improving Patient Safety. My name is Kathy Reynolds, and I'll be your moderator for this program. Now I'd like to introduce your speaker for the webinar. Mary McGee serves as a Senior Patient Safety Quality Analyst for the Pennsylvania Patient Safety Authority. She is responsible for reviewing and analyzing adverse event reports submitted to the Pennsylvania Patient Safety Reporting System, and uses this information to develop articles for the advisory, continuing education programs, webinars, and presentations to inform and educate Pennsylvania healthcare facilities about patient safety issues. Ms. McGee collaborates with the authority staff and the board in leading the Patient Safety Measurement Strategic Project, which included the development of a patient safety measurement dashboard. Mary has over 20 years of patient safety, quality improvement, and regulatory affairs experience in healthcare, as well as 12 years of progressive management experience. As Senior Director of Quality, she led the strategic initiatives for quality improvement, patient safety, accreditation, and regulatory preparedness at a multi-hospital health system that included the comprehensive all-mortality review process, quality dashboards, and served as the patient safety officer. She provided comprehensive clinical nursing care in the specialties of pediatric and adult emergency trauma care and medical surgical care. She also holds certifications in healthcare quality and in patient safety and is a Team Steps Master Trainer. Mary, I will now turn the program over to you.
Thank you, Kathy, and welcome everyone. Thank you for joining us today. Healthcare facilities may find it challenging to quantify the impact of patient safety and quality improvement initiatives or build a business case for initiating such projects. During this presentation, I will demonstrate a standardized cost and mortality estimation methodology that the authority used to appraise the value of data aggregation, analysis, dissemination, and statewide collaborative learning to reduce healthcare-associated patient harm in the state. We hope that by the end of the presentation, you'll be able to describe the methodology used to estimate lives and costs saved, identify a patient safety or quality initiative, perhaps at your own facility, whose impact could be quantified by this methodology, and then list a potential set of patient safety metrics to apply this methodology to. Back in December, my co-authors and I published the value of patient safety in Pennsylvania in the Patient Safety Advisory. We thought it important to further the conversation about assessing the state of patient safety in general by describing the efforts in Pennsylvania. Those of us in healthcare quality and patient safety must continually question whether safety is improving and whether the industry's efforts are yielding meaningful results. Industry leaders such as Mark Chasin of the Joint Commission, Peter Pronovost of Johns Hopkins, and Bob Wachter of UC San Francisco have noted and published on how difficult it is to adequately measure patient safety and the value of such improvements. The authority's charge under MCARE is to reduce and eliminate harm from medical errors by collecting and aggregating data, identifying problems, and recommending solutions that promote patient safety. We estimated the value of this charge and that of statewide collaborative learning and modeled our approach on similar methods of extrapolation and estimation published by the CDC and the Agency for Healthcare Research and Quality, otherwise known as AHRQ. Improvements have occurred with concentrated efforts directed at discrete issues. The literature shows that broad estimates of lethal harm during hospitalization have ranged from 250,000 to 400,000 annually. Even if they are overestimated, the number of preventable harms is still large, and any progress that can be made should be made. A select set of patient safety measures were chosen by the authority to demonstrate the results of the combined efforts of Pennsylvania healthcare facilities such as yours, statewide quality improvement entities, and the authority itself. We estimated that through 2015, more than 2,600 lives and more than $147 million were saved. You may find this cost and mortality estimation method useful by applying it to measures of importance in your facility to demonstrate the effectiveness of patient safety and quality initiatives. Using acute care data submitted to the Pennsylvania Patient Safety Reporting System and the National Healthcare Safety Network, the authority computed event trends and used evidence-based mortality and economic estimates to calculate theoretical lives and dollars saved over a reporting period of 11 to 12 years. These measures that you see on the slide, with the exception of high harm events, were selected because the authority had established focused collaboratives on these topics, standardized definitions and monitoring methods, and engaged providers in making improvements in these areas. High harm events were selected as a potential global measure of safety. We acknowledge that the authority is not the sole contributor to these improvements. The CMS's Partnership for Patient Care and subsequent Hospital Engagement Network collaboratives occurred during this timeframe. The federal government's non-reimbursement for these never events also prompted hospitals to focus on these and other events through quality improvement initiatives. Statewide quality improvement entities such as the Healthcare Council of Western Pennsylvania, the Healthcare Improvement Foundation, the Hospital and Health System of Pennsylvania, and Quality Insights led or co-led or participated in many of these same initiatives. The measures we will discuss today include falls with harm, the central line associated bloodstream infection, otherwise known as CLABSI, and high harm events as an overview. Extensive literature searches were conducted on factors such as mortality and cost in the medical and economic literature. Both AHRQ and the CDC use similar approaches when estimating dollars and lives saved from reducing hospital-acquired conditions. Analysts then estimated the theoretical value of avoided events based on the cost of claims and or additional cost of treatment. Cost information for these data measures has been adjusted for inflation using the Bureau of Labor Statistics publicly available Consumer Price Index. When necessary, for example, in the absence of definitive and specific measure information, estimates were used and validated internally through the literature. So let's look at the value figure and the formula used. Now, through this next section, I will go through it kind of quickly, but towards the middle of the presentation, we'll go slower through a calculated example. So performance of each measure is evaluated over time, as can be seen by the years represented on the slide. The actual number of events per year was plotted in a line chart or a run chart. Actual performance is presented by the solid blue line and are the actual results of the data of the measure over time. Expected performance is represented here by the solid orange line and is derived from the baseline of the trend. This assumes no change over time, and we'll talk a little more specifically about the detail of that. The linear trend line is represented by the dotted black line and was calculated using the Trendline formula within Excel. And then the shaded area represents the difference between the expected and actual performance. We use the slope of the line formula to calculate the estimated projected measure avoidance, the mortality prevented, and cost saved, as we can see in the next slide. The value formulas here are all estimated projections. In the first table, the value formula, the difference is calculated by subtracting the actual performance from the expected each year and then totaled, as seen by the first red arrow there, the 118. For mortality, we took the estimated cases prevented or avoided, multiplied that by the estimated mortality per case to get potential lives saved, as indicated by the 5.9. Similarly, for cost, we took the estimated cases prevented or avoided, multiplied that by the estimated cost per case to get potential savings. So now let's go through our value data for the three measures one by one. The value formula calculated for falls with harm uses an estimated excess cost of mortality for these hospital-acquired conditions and also includes that for CLABSI. The source of this information is the interim update on 2013, the annual hospital-acquired condition rate and estimates of cost savings and deaths averted from 2010 to 2013. This is the most current information at the time of publication and was based on R. Douglas Scott's original publication called The Direct Medical Costs of Healthcare-Associated Infections in U.S. Hospitals. That was published in 2009. Both of these reports use results from the published medical and economic literature. So using the value formula previously described, we estimated more than 2,200 potential falls with harm were avoided between 2007 and 2015. Regional and statewide learning contributed to these improvements. Between 2010, a joint effort between the authority and HCIF, there was a falls reporting initiative during that time, and then the authority led partnership with HAP in the HEN Falls Prevention Collaborative. The authority published numerous articles and resource tools, but the facilities actually did the work, which is what these slides show. Before these efforts, falls were on the rise and falls with harm were on the rise. Using the value formula described for CLABSI, we estimated that more than 5,000 potential CLABSIs were avoided between 2008 and 2015, over 900 estimated lives saved, and approximately 99 million estimated potential saved. For high harm, the value formula uses an estimated mortality and cost that we identified in an article published by Adler in 2015, who studied the impact of inpatient harms on hospital finances and patient clinical outcomes. Again, this citation is also on the resources slide at the end of the PowerPoint. High harm events are those events reported with a harm score of G, H, and I, and should be familiar to most Pennsylvania hospitals. These events are seen as a leading indicator for serious events and have been decreasing in number and percentage of serious events. We estimated that more than 2,200 high harm events were avoided between 2004 through 2015, and that over 1,300 estimated lives were saved and approximately $1.5 million in estimated potential cost savings. In addition to what has been discussed, QI projects and initiatives have been performed by the authority and others throughout Pennsylvania and have contributed to the reduction in harm to all patients. This table is a summary of our potential estimated lives and costs saved for all measures, as discussed in the article. In total, through 2015, more than 2,600 lives and more than $147 million are estimated to have been saved with an average annual cost savings of $20 million. By comparison, the general efficacy of patient safety initiatives is supported by AHRQ's research on national rates and cost savings and deaths averted, which shows an estimated 17% decline historically, and estimates from 2015 show a hospital-acquired condition rate 20% lower than 2010. They estimate 125,000 fewer patients died in hospitals as a result of a hack, and approximately $28 billion in healthcare costs were saved. So why estimate lives and cost savings? Well, there are advantages to using estimations, including furthering the patient safety discussion. Specifically, it helps quantify performance improvement activities, helps teams and directors justify resources such as personnel, teams, and activities in risk and quality and patient safety improvements. It helps market improvements, and through those improvements, you achieve quality and safety scores and improvements in those scores, and also also contributes to the positive balance on reimbursement. It also helps engage both patients and physicians and helps improve patient, physician, and staff satisfaction. And it's a good foundation for establishing the business case, which so often can be a challenge for patient safety, quality, and risk providers. So how can you use our estimation method in your facility? Well, to get started, we have basically 6 steps that we're going to share and walk you through over the next several slides, and they're reflected here. So let's take each one separately. So you'll identify a set of measures important to your facility, your strategic objectives, or perhaps their organizational priorities. They may be found or defined in your quality improvement plan or in your patient safety plan or through some other such feedback mechanism. Take the time to research data and information that's already been published on your selected measures. Chances are cost and mortality estimates exist and are often found on websites such as AHRQ's or the CDC or similar. So let's recall the falls with harm example I spoke about earlier. Let's take this measure and go through each step in the process. You'll start by creating a run chart. You'll have your actual performance entered into a spreadsheet product like Excel, as shown here in the top bar. You'll create a line graph of your data, as seen here, plotted over time. So once your run chart is created, you'll right-click on it to pull up the chart elements selection box by clicking on the large plus sign that's seen here in the red circle. Then look down that list and check the box next to the word Trendline. Once this is checked off, a dotted trend line will appear on your graph. In order to obtain the calculated expected performance number, click the arrow next to the word Trendline, and the Format Trendline dialog box will appear, as seen here in gray. Look all the way down to the bottom, and you'll see something called Display Equation on Chart. Once you select Display Equation on Chart, this Y formula will appear. The second number in the formula is the calculated expected performance and is what we used in all the previous examples as holding constant over time. So in other words, this formula assumes a level of expected performance based on actual performance and the trend of that performance. This holds constant and is used to calculate annual differences, as we'll see on the next slide. And we use these annual differences to calculate our projections. So here you'll create a table for each year, and I should point out that if you have data that is more frequent than a year, or perhaps you're estimating the results of a project, you may be reporting monthly or quarterly data. We chose to use annual data because we had several years of information to share and to measure. So once you create a table, enter the expected performance number from the previous slide in the table next to each year. That's seen here in the red box. Enter the actual performance and calculate the difference for each year. Total up those differences as seen here by the red arrow. And in this example, it comes to 2290.10. So using the differences total as seen by the red arrows here in these two examples of mortality and cost, you'll multiply that total by the mortality and cost estimates you found in your research. In this example, I used the published data available from AHRQ's Hospital Acquired Conditions Update Interim Report that I mentioned earlier. The result of your calculations will be the estimated potential lives and dollars saved, as indicated by the yellow arrows. Remember to adjust your cost estimations for inflation. So if you found cost data from 2015 and you're estimating what the savings will be in 2017, adjust your cost estimate to those 2017 dollars. In fact, the Bureau of Labor Statistics has a very nice inflation table that you can use for this reason. And I've listed that site on the resources slide as well. Now that you have your lives saved and cost savings estimates calculated, you'll want to promote and share your results across your organization and with others. Be a little strategic in your thinking when it comes to sharing results. Certainly you'll want buy-in from leadership, especially the C-suite, but specifically the Chief Financial Officer, who you actually might want to approach prior to doing these calculations, not only to get their input, but perhaps they could also share with you your own facility's actual costs. So rather than relying on what's reported in the literature, they may have access to actual cost data for your facility that you could use in these calculations so that your estimates would be a little more closer to reality. Certainly physicians, I'd recommend sharing this not only with physician leadership, but at committees such as Medical Executive Committee or Physician Quality Committees. They're very interested in practice patterns, and they are very interested in learning how to improve based on data and information so that if they see it from their own facility, they'll be more engaged. Certainly share with management and staff. You could use venues such as town hall meetings, your internal internet web page, share at management meetings, staff meetings. Patient Safety and Quality Improvement Committee and certainly the Risk Management Committee would be other venues in which you might want to share this information. And then market the progress that you're making to the patients and communities. And then certainly the regulators will also be interested. It's basically a different way to present results so that you're not just showing that you improved over time, but you're showing the impact of that improvement. So, for example, you're telling them what the improvement actually means. I also think it's important to be transparent in your methodology. Be open and share exactly how you reach these calculations. Use the current literature to support the evidence that you're using. And again, use your own costs if you're able to. So in summary, as stated previously, measuring the value of patient safety is challenging, and estimations will be inherently imprecise. But I suggest those of us in patient safety must always try. We must make the good faith attempt at measuring and monitoring. The authority believes the improvements made in Pennsylvania by healthcare providers in these focused areas are substantial and meaningful. Even if the estimated values are off more than marginally, these improvements did occur and reduced human suffering. Although all of these reasons for the progress are not fully understood, guidance and assistance from quality improvement organizations, the Health and Human Services Partnership for Patients, financial incentives, and public reporting of hospital results are cited among the contributing factors. So, Kathy, I will now turn the program back over to you.
Thank you, Mary. That was a very informative presentation that contained valuable information everyone can use in their organization. That concludes our slide presentation portion of our program. Now we would like to begin our question and answer period. We do have a few questions, Mary, and I'll start from Jennifer Gregory. Can you review how to get the expected Y value again?
Sure. So if we go back, and if you have Excel, it's a lot easier. I will tell you that. But again, this is something finance should also be able to help you with. So inside of Excel, when you've created a chart, and you then select the trend line, if you click on that arrow next to the word trend line, this other dialog box opens. It's called Format Trend Line. And there's a lot, this is a busy dialog box when it opens up in Excel. But all the way at the bottom, you'll see this display equation on chart. When that box is clicked off, you will then get this formula called a Y formula. And I am not a statistician by any means, but basically what this means is it gives you a placeholder. So the 1375 is a placeholder, and that is meant to be static across the entire period of your project. So you hold that steady, and it assumes that there's no change, even though we know there are changes for the purposes of statistics in this formula. We make an assumption that there's no change because we need a starting point and we need a place from which to measure a difference. So that number is what we use as our baseline across for the duration of the project. And then we use the calculations in here. So we take each year's actual performance and subtract it from the expected performance to get the difference. And then we total the difference. Thanks, Kath. Any other questions?
We do have one more question if we could get in quickly for the cost for, regarding the cost for falls, where did the 8,110 per fall number come from?
So could you read that again, Kathy, that last part of the question?
Yep. Regarding the cost for falls, where did the number, or the, in dollars, 8,110 as a, cost per fall number come from?
I'm assuming she means the 18,000. So we did that via that table calculation I had displayed earlier. For example, here, this is a calculation example, but it'll serve our purposes for the falls. So basically, in the bottom of this slide, you see this cost table. So we would input the number of estimated falls with harm avoided over time. We multiplied that by the estimated dollars that we then found in the literature, and that's where we got the estimated potential savings of the 18,000 for the falls. Hopefully that does answer that individual's question.
Okay. Thank you.
I think we have, yeah?
I think given the time, we will move on, and any additional questions, please feel free to forward to the authority, and we'll get you, get some of those answered for you. So thank you, Mayor. I want to thank everyone for joining us today. This concludes our webinar. Thank you.